So, good evening, everyone. My name is Raunaq, and today I'll be talking a little about Bleb-related endophthalmitis. The moderator for the session will be Dr. Janani Sreenivasan. So, this is a story of a 45-year-old male. He came with the complaints of pain, redness, and diminution of vision in the right eye since one day. He was diagnosed with juvenile onset open angle glaucoma and has had a trab in both the eyes in 2006. Since 2006, he has had multiple procedures of trab and needling, and the last intervention in the right eye was done in 2015. Currently, he is not on any topicals. So the vision in the right eye at presentation was PL, left eye 66 N6. External examination was unremarkable. Right eye anterior segment conjunctiva showed severe congestion. The bleb was milky in appearance. But it was Seedles negative. Cornea showed presence of some KPs. The aqueous was full of fibrin and hypopion and cells, and the pupil was sluggish to reaction to light, and there was a fibrin over the anterior capsule of the lens, and the pressures were high. It was recorded to be 35 milligram of mercury. In the other eye, it was normal. Anterior segment was unremarkable. So we performed an ultrasound because the fundus view was not adequate. This is what you see. Very few echoes, almost similar in both the eyes. So we did an AC tap and subjected it to microscopy and culture, and started the patient because of the presence of the fibrin over the anterior capsule and the plasmoid aqueous and other anterior chamber cells and flare.
Actually, it was not dilating also, sir. Very poor pupillary dilatation with severe AC reaction.
So the B scan, we started him on intensive topical therapy and of antibiotics, and right after 12 hours, next day in the morning, performed a B scan again. Here you can see that he has developed vitreous echoes more in number, and now we decided to inject. We performed an VCD. So the next day, vitreous inflammation was still persistent. Underwent one more injection the day after. So on the 26th, this is the clinical picture. You can see there is congestion, the typical white on red appearance of the bleb. And but the good thing now is the anterior chamber is much clearer. You can see a fibrin which is retracting over the circular in shape over the lens surface. The hypopion inferiorly is also become organized. The ultrasound is still showing echoes though. Underwent one more injection on the 29th. Again, on the anterior segment, you can see clearly the inflammation has come down. The fibrin is almost not there. Hypopion cannot be seen in this image, and the fundus view is also clearer. The patient was improving as we were observing him every other day and every day for the first few days. You can see the drug precipitate in the eye inferiorly. And then he came back again on the third. Vision in this eye now is 6/36. He has a PSC. Anterior chamber is clean. There is still some congestion and some inflammation. Fundus view is much clearer. In fact, you can even notice and appreciate a lattice superiorly now. So this brings me to my talk on bleb-related infections. It's important to classify them. They can either be blebitis or Bleb-related endophthalmitis. It's important to classify them as follows because this has bearing on management and prognosis as well. They can also be classified as early and late. Early is when it is less than 1 month, and late when it is more than 1 month. Both pathophysiology here is different and prognosis is different, and hence it's important to classify them like that. The stages of the disease are as follows. The first stage is when only the bleb is involved. Here you'd get only erythema around the bleb. You may have a milky appearance of the bleb and loss of its clarity. Sometimes you may see a hypopion as well. Stage 2 is when there is AC involvement. Here you would see cells and flare and hypopion in the anterior chamber. And stage 3 is when there is vitreous involvement. Stage 3 is bleb-related endophthalmitis. Vitreous involvement is further subclassified as A and B. A is mild and B is severe. So a study by Mukammal et al. Demonstrated that in eyes which were phakic, the time for development of bleb-related endophthalmitis from blebitis was around 1.75 days, And for pseudophakic patients, it was around 2.5 days. So it's extremely important when you see a patient with redness, pain, and diminution and a history of TRAB to follow them up for at least 3 days more closely to watch for signs of evolving endophthalmitis. So various risk factors have been described. Location of the bleb, in terms of location, inferior ones have a higher risk because of loss of protection of the lid, and the nasal ones because of the exposure of the lacrimal lake. As far as the type of bleb is concerned, an elevated thin avascular cystic bleb carries a higher risk. And as far as surgery is concerned, in terms of the approach, the limbal approach yields a more elevated thin cystic bleb and hence is considered to have a high risk as opposed to the fornix based one, a leaking bleb, and those with postoperative bleb manipulations obviously increase the risk. As far as MMC is concerned, initial reports suggested that there is a high risk with use of MMC, but over time the cumulative incidence has evened out, and this is attributed to the betterment of the surgical techniques. In terms of type of surgery, TRAB alone carries a higher risk than when conducted with a cataract surgery. In aphakics and pseudophakics, the risk is higher. Blepharitis and conjunctivitis increase the risk. Again, post-operative complications like wound leak and suprachoroidal hemorrhage and AC shallowing, which would require interventions in the post-operative period, increase the risk. And chronic use of antibiotics has also increased, has been associated with an increased risk of development of Bleb-related infections. So clinical features would be abrupt onset pain, discomfort, redness, and blurring of vision. And you look for the signs like intense injection at the bleb area, loss of its translucency. You may see a hypopion within the bleb. AC would show cells and flare and hypopion, and you may see fibrin, and vitreous would show vitreous haze. So how do you work this patient up? You ask for the history, the times in surgery. As I said, it's important to classify between early and late because that has bearing on prognosis. You look for systemic disease and uncontrolled diabetes because you need to do a holistic approach and control those things as well. As far as type of MMC your procedure is concerned, use of MMC is important because sometimes if he has been treated long ago, may have had a more higher dose of MMC, and in those cases, the conjunctiva may be necrosed and may have a sedals and may have a persistent fistula. So even when you're operating, you may need to augment here with a scleral patch graft. Look for Roplas, assess the corneal status. If you need TPK or a temporary keratoprosthesis, that's why it's important. Look at the bleb and do a sedals. How do you do a sedals? You put a drop of paracaine, you ask the patient to look down, and on the cobalt blue filter, you rub against the bleb with the fluorescein strip. You can see the dye is diluting the fluorescein. Again, you can see clearly how the fluorescein is being diluted by the dye. That is a positive test. So grade the cells and flare and the vitreous cells, measure the height of the hypopion. Now, how do you measure the height of the hypopion? You do it in the sitting position. Most of our patients in the post-operative period are lying supine in the ward. So when you are going for to reevaluate them in the post-operative period, you would almost never find a hypopion because they've always been lying supine. So ask them to sit straight, or instruct the nurse to ask them to sit upright before you visit the ward, at least for half an hour. Grade the vitreous haze and perform an ultrasound. Signs that are suggestive of endopht are posterior vitrecose and choroidal thickening. It's important to rule out choroidal detachment and retinal detachment in these cases. Also look for a T sign. Document. It is important to monitor for monitoring of the disease, especially when multiple clinicians are involved, and it will also help you in medical legal aspects of the game. So as far as microbiology is concerned, you can do a conjunctival swab, AC tap, vitreous tap in vitrectomized eyes, and a vitreous biopsy in non-vitrectomized eyes. So you subject it to microscopy, grams and KOH. You can even perform a GIMSA, do a culture and antibiotic sensitivity test. You plate it on chocolate, blood, and sabrods. And for the liquid, you have the thioglycolate broth and the brain heart infusion broth. And nowadays, the yield has increased for the test with the use of PCR. You can even identify the organism on next generation sequencing. The question is, do I need to do all of them at presentation? So this was answered by a study by Yamamoto, who said that if only the bleb is involved, you can get away with only the conjunctival culture and the discharge. However, if AC is involved, you need an AC tap, and if the vitreous is involved, you go ahead with the vitreous tap or a vitrectomy. So, as far as organisms are concerned, early infections are similar to those seen in acute postoperative, where it is mostly coagulase, negative staphylococci or staph aureus, and it is hypothesized that these are usually because of inoculation during the perioperative period. And in the late phase, it's now these organisms are the highly virulent one and highly pathogenic, and most of them are gram negative, having a lot of exotoxin, which cause a lot of inflammation and damage to the eye. So streptococci is the most common, followed by enterococci, H. influenza, moraxilla, and staphylococcus. And here they theorize that these organisms are only transiently present over the surface of the bleb, and they can go through because of their ability to secrete exotoxins. So the role of conjunctival culture has been questioned. A lot of studies give variable responses. Some of them have documented that yes, it does have a role, but in most studies they have found that the culture of the conjunctiva versus that which was grown intraocular are of different microorganisms, and you would tend to treat on the intraocular culture. In fact, Mandelbaum et al. Did a study where they even rubbed the cotton tip swab vigorously over the bleb, and they cultured that and they compared it with the vitreous and the AC tap, and they found different results and different organisms growing. Also, if you tap a bleb, it may lead in chronic leakage, and this may lead to a loss of that filter, which may survive the endophthalmitis, especially nowadays with the 25 gauge era. A positive bleb culture, also, you cannot rule out colonization versus infection. So its role is limited. How do you perform an AC tap? Use an aseptic technique. You can use a drape. You administer a topical anesthetic, put a drop of pyridine iodine, use a cotton tip applicator to stabilize the globe, usually at the opposite end of the direction in which you're going to go. You take the injection 30 gauge mounted on a tuberculin syringe in the dominant hand, and you obviously avoid the bleb area. You can go either at so you can either go superiorly or inferiorly in a lamellar fashion at the iris level. Don't aim directly at the center. You may lead this has a higher incidence of lens damage. You can go either superior from 6 o'clock or 3 o'clock, inferior or superior, however you feel. You can use either active suction or passive suction. When you're using active suction, make sure you pop it open before you enter the eye. Sometimes in a hurry you may just enter, and then the initial vacuum of the tuberculin syringe is quite significant and may cause AC shallowing and collapse. When you're using a passive suction, you can tap the center of the cornea. This will force the aqueous to go into the angles, and you would get a better yield. In either cases, do not cross the pupil. As far as treatment is concerned, the aim is to control infection. It is also to control inflammation. They go hand in hand, and it is to restore vision. How do we do this? We do it by giving therapy either locally or systemic. Local is either topical, intravitreal, or vitrectomy, or a combination of either all. So as far as topical therapy is concerned, you can start with a fourth generation fluoroquinolone, either Gatiflox or Moxifox, 5% every 1 hour after a loading dose. What is a loading dose? You give 1 drop every 15 minutes for the first hour. Or you can go ahead with a fortified vancomycin, 25 to 50 milligram per ml, and tobramycin or Tobra, alternating every half hour for the first 24 to 48 hours, again after a loading dose. Here, the role of steroids is a little questionable because there is an element of surface infection. You definitely don't want to increase that. Also, the bleb is very thin. You don't want it to ulcerate. So, usual recommendation is to start steroids after 24 hours of topical therapy in the form of antibiotics, or when clinical improvement is documented. you can taper to regular strength after 48 hours. So as far as systemic therapy is concerned, initially EVS said that there's no role, but subsequently better and better antibiotics came into picture, and they have documented that they do reach the minimum inhibitory concentration in the vitreous, especially the fluoroquinolones. An oral ciproflox 750 milligram BD or a moxiflox 400 BD or gatiflox 400 BD is recommended. And in fact, the penetration is even high in inflamed eyes like ours. And you can start oral steroids after 24 hours of antibiotic use or when there's evidence of clinical improvement. As far as intravitreals are concerned, the initial choice of therapy is empirical VCD. Keep the injection chart ready and dilution, refer to the chart for dilution, because one small error here can lead to 100 times concentration of the drug in the eye. And you remember that these drugs are also retinotoxic, so you definitely don't want the wrong concentration in the eye. Apply topical anesthesia, apply a lid speculum, put a topical drop, put topical pivodine iodine. Check the IOP. If it is too low, do an ultrasound, rule out a choroidal detachment. Definitely don't want to inject in the same quadrant as the choroidal detachment. If it is high, then you can perform an AC tap at or in before or after the procedure. As far as how to inject, you can do it with the 30 gauge, 3.5 millimeter from the limbus, and you use separate syringes for the antibiotics. You can combine C and D in the same syringe. So if you are going ahead with intravitreal injections, examine the patient every 6 to 8 hours for the first 24 hours initially, because as I said, these are highly pathogenic bacteria, and they can the things can progress and go really fast, and so you don't want them going home and then coming back with a fulminance in the clinical picture. If at any point there is no signs of if there's signs of worsening, better to go for vitrectomy. Repetition of injection is based on the half-life of the drug that you injected and the status of the vitreous cavity. VC and D can be repeated after 72 hours. So we can even go for a vitrectomy state up. I'd like to answer a few questions like why, when, and how, and I would like to do it in the next few slides. So why do you do it? Vitrectomy reduces the load of the infection. Not only that, more importantly here, it can reduce toxins which are there within the eye. You can get a good sample for microbiological assessment. It leads to rapid restoration of visual function, and also has a beneficial effect in terms of distribution of the antibiotic within the eye. So for treatment purposes, for Bleb-related endophthalmitis, the treatment has not been prospectively studied. So prior to EVS era, the ratio for prompt vitrectomy in cases with Bleb-related endophthalmitis was around 86%. And after EVS came with their recommendations of going with initial tap and inject, many clinicians extrapolated those results onto Bleb-related infections, and hence you can see a steep drop in the rate of prompt vitrectomy for Bleb-related endophthalmitis. So we need to ask a few questions. The question is our Bleb-related endophthalmitis different from acute postoperative endophthalmitis? And second, does EVS criteria hold true in today's era of MIVS, and does it even apply for Bleb-related endophthalmitis? So the answer is yes, they are different. Bleb-related endophthalmitis is caused by more highly pathogenic bacteria, and hence these bacteria are more virulent than those in post-operative post-cataract endophthalmitis. Also, topical steroids cannot be started immediately because of the surface may have an infection as well. So inflammation takes longer time to subside. Poor visual outcomes are documented despite aggressive therapy. And IOP control is also compromised after an infection. So to extrapolate the results of acute postoperative endophthalmitis onto Bleb-related endophthalmitis may not be the right thing. So should we inject or should we go ahead with vitrectomy? A lot of people looked at this question and tried to answer. Most of these studies are retrospective in nature. So Song et al. Looked at their group and found that only 36% of their patient which had initial vitrectomy had a vision of 20 by 400 or better, as compared to 69% that underwent initial tap and injection. So, but there's a huge clause here. There is a selection bias. Only the severe cases were taken up for vitrectomy. So initial poor vision, obviously, we know that has a prognostic factor, has a lower outcome. Bushby et al. Again studied the same question. They, in their study, found that the prompt vitrectomy group had better outcomes in terms of vision gain, and had lesser likelihood of severe visual decline and lower incidences of NPL. And so they recommended that you should go ahead straight up with vitrectomy, or at least do vitrectomy in culture positive cases which do not respond after your first injection. But recent reviews by Mukammal and Robbins have not demonstrated any difference in terms of visual acuity in both the groups. But they did observe that a high number of patients that initially were injected ended up requiring vitrectomy. So this suggests that the infection may not resolve by intravitreal injections alone, and sometimes you may have to go for vitrectomy, and this is regardless of the presenting vision. So what is our approach? Our approach is that vision alone cannot determine the mode of treatment. Clinical presentation should determine the mode of treatment. You need to classify the infection as blebitis of endophthalmitis. If it is just blebitis, you start and treat aggressively with topical systemic with or without conjunctival injections, subconjunctival injections. It's important to note that even though only subconjunctival injections are recommended, a recent survey found that around 24% of consultants in the UK still go ahead with intravitreal injection, even in cases of blebitis, because of the aggressive nature of the disease. So what do you see? If you see improvement at 24 hours, you continue the same. However, if at any point you see worsening, or if there is no improvement at 24 hours, or if there is endophthalmitis at presentation, but it is of the mild caliber where you can see second order vessels, then you can go ahead with injections. Again, reassess at any point. If it is worsening, go ahead with vitrectomy. If it is improving, then you continue the same. As I said, if the infection is of the severe kind, or if there's no improvement at any point, you go ahead with vitrectomy. So how do you do the vitrectomy? In terms of vitrectomy, it is not very different from a standard vitrectomy you would do for an endophthalmitis. You look at the cornea, assess the clarity. Don't hesitate to remove the epithelium here, because visualization is key in these cases. Because of hazy media or difficulty in visualization, your risks of iatrogenic complication increase drastically. So remove the epithelium. It is if you think it is contributing to the haziness. Assess the bleb. If it is leaking, you may need a patch graft there. As far as side port is concerned, you avoid the bleb area. That is obvious. You clear the anterior chamber of the exudates and the membranes. It's easy to do this with the help of a forceps. You can start at the margin of the iris and then slowly nudge it out. Once you're done with that, you go ahead and fix the infusion line, collect some sample. You can infuse air to avoid globe collapse. You send the sample for microbiological evaluation. Start infusion after you have verified the infusion cannula is in the vitreous cavity. Start from up to down. Do a port site vitrectomy first. Here, it's important to do port site at the infusion cannula as well, because sometimes the exudates are so thick that if you don't do this step and start going ahead, you might have more often get a globe collapse or a reduction in IOP as you progress in the case. Do a good anterior vitrectomy. Perform a PC opening if the case is a pseudofake. This will increase the distribution of antibiotic within the eye. But where do I stop? Do I need to induce PVD in all? So EVS recommended do only core, stop at when you visualize the disc and macula. But newer, with the advancements in the techniques and developments of better technology, newer studies suggest that, if possible, do induce a PVD and clear the macula of the exudates. This helps prevent formation of a macular hypopyon in the postoperative period, and that is associated with poor outcomes. But in the periphery, you need to be conservative. Don't be too aggressive. What about silicone oil? Do I need to put oil? So the benefits of putting oil are documented. Antimicrobial activity of oil is well known, especially against bacteria. RCTs have been performed, and they have said it has better rate of infection control, better outcomes, lesser rates of reintervention, lesser rates of retinal detachment, and lesser risk of hypotony with primary oil use. However, oil is a double-edged sword. It does not come without its side effects. The side effects would be that oil sequesters and causes compartmentalization. So all the space that would be occupied by the aqueous is now replaced with oil, and only a very thin margin of aqueous is available between the oil surface and the retina, and all your toxins are going from the retina, are getting secreted and sequestered there, and so the retinal surface is more exposed to these toxins. So, and also there's a risk of a biofilm formation in, and this is more for the chronic endophthalmitis, and it has no role. Its role in fungal endophthalmitis is questionable. As I said, toxin washout is reduced. It Dosing of antibiotics is also, you need to alter with an oil-filled dye. And as I just explained, compartmentalization takes place. So toxins may be more exposed towards to the retinal surface than you would want. So as far as now, oil is only taken, not put primarily only when you have a break. Obviously, if you have a break, you would do endo laser as well. So the take-off message for my talks is that Bleb-related infections are urgent and they require intensive treatment. Treatment should compromise of combined therapy in the form of topical, subconjunctival, intraocular, and systemic antibiotics. The role of steroids is not known, but is usually recommended to start after 24 to 48 hours of antibiotics, or if infection is controlled clinically. Vitrectomy is recommended when the vitreous involvement is severe or apparent. I thank you for your patient listening. This was a group effort. It would not have been possible without the moderator, Dr. JSN, and my mentor, Dr. RRN. Thank you.
Thank you, Ronak. Just go to the case. There's few points I would like to add with the respect to the case. So one, this is around 9 o'clock in the night on 22, and this is morning around 10 o'clock. So just matter of 12 hours, we can see the number of echoes increased in a phakic patient. So this needs very close monitoring, more than a routine postoperative endophthalmitis. That is one. Second, this all these patients have element of surface infection, so not we won't be able to start topical steroids. Hence, the amount of hypopyon or inflammation subsiding with injection in a routine post-op versus this would be little slower. But still, we started only after 2 days of intense antibiotic therapy. And if we see the superior bleb area is very thin in this case, especially. So we were hesitant to take a swab, especially since a patient came at night. Because if this patient right now the blood was not leaking, if it leaks and the AC becomes shallow, it becomes, it's a difficult situation more than what it is now. And secondly, we did inject steroid along with intravit, means we gave VCD, and after 4 5 days we started him on oral steroids as well. Actually, the last picture where the lattice is seen, that from this, go back, from this, this kind of inflammation with haze was still persisting. So we started him on oral steroids along with injection. He improved later. Now he still, we are following up every alternate day, and the blood is also not leaking. And from, I think, counting fingers or hand movements, he improved to 624. So the most important key is close follow up. He was admitted for the first 5 days, and we have been seeing him like morning, evening, that way. Because more so in a patient where we have not considered vitrectomy as the first choice. On day one, we didn't consider because hardly any viticos, phakic patient. On day two, because the echos were increasing, we injected. So we had already got clearance for LA. We have primed the patient for vitrectomy actually. But since he was improving, the fundus view increased, then we stick to injections only. But most of the studies shows when fundus view is not there, prefer vitrectomy, like direct.